Hi, everybody. It's Kevin and Jenna from RPH Ally. So excited to be with you guys today. And this one is a really special one because we're starting something new at RPH Ally. And Jenna, just like Jenna always does, jumps on it and knows how to get it done. So I sent something out last night and said, hey, the one thing that we're going to look at doing is shows. We really need to give some consistency to this world. It feels like it's just always, hey, one random blast after the next. And so this is the first episode of the Perfecting Peds show with your star, Jenna Quinn. And so I'm so excited to talk about our topic today. Talking about something that folks are really going through, I think, in terms of difficulty that Jen and I, just before we started the show, were discussing. And this month has been rough. I was reading a couple articles that showed like the attendance level inside of offices went from somewhere around 50 to 60% down to 30% from December to January. And, they were going over some of the reasons, and, some of them were just the economy and some of the concerns of what's kind of going on in general, folks having issues with depression, the problems with remote work versus in-office work, making that transition after these weird last 2 years. And one of the big ones was the holidays didn't feel like the holidays, Jenna. And I know your family and my family got hit with that because our kids were sick and really sick and sick multiple times. And so I want to pass it over to Jenna to tell us more about, what's kind of going on there. What are the other issues that are happening in the space, because of those number of sicknesses and some shortages, and then give us some help on what do we do next. So Jenna, off to you.
Hey, so this is an easy topic to discuss because just as Kevin said, when you have 3 kids, one of them during the past couple of months, or I would say 2 months, have been sick at all times. So it's been like a continuum. And as a parent, we need our sleep. And when you have 3 kids and they're all either one or all of them are sick at the same time, it does definitely hit you, and it's hard to function when you have multiple sick children and they're rotating and you're not sleeping. So this one is an easy topic to talk about because I have multiple personal experiences that I can share from. So basically, we went from the pandemic, which my second child was, so I have 3 kids. I have a 5, a 3, and a 9-month-old. And so my 3-year-old was about 6 months when the pandemic struck. So she didn't get exposed to a lot of these viruses now that we're all getting exposed to, and it's all at once. So she honestly has been the sickest of all of them. And I think because as a lot of infectious disease doctors have hypothesized, it's like those past 2 years, they had this ideal or really non-ideal immune system where they weren't exposed to a lot of things. And then we took off all our masks, and then we had historically, RSV has always been an issue, but it's definitely spiking. Interestingly enough, it didn't. This year, it actually, from working in the hospital, we never had issues with it over the summer. But as we started to take off masks, it actually started to evolve in the summer, but now is spiking, which we usually see. And then we have COVID, of course, and we have influenza. And then obviously your normal sprinkles of like cold, your para-influenza, your adeno and rhino. So there's a lot of viruses in it, and a lot of actually pediatricians have asked the CDC. There's multiple articles how pediatricians are asking the CDC to essentially call this a health crisis. And many pediatricians that I've talked to said this is 20 times worse than the pandemic was, specifically in the pediatric population, because of how many viruses there are out there, but then also in addition, the secondary bacterial infections that almost every child is getting. And then what kind of led me into this is almost every child has a secondary bacterial infection we're seeing. So it's either otitis media or pneumonia, which all my girls have had. And then that leads us into drug shortages. So because of this, tri-pandemic we have going on, I first want to start off with how can we avoid this? So if possible, well, now they make it a lot easier. Thank God for pharmacists in the retail setting that you can get your son or daughter or your child immunized very easily unless they're under the age of 3, where you'd have to go to the pediatrician. Like my 6-month-old she did need it, like, to go to the pediatrician to get hers. If it's your child's first flu season and they're under the age of 8 years, so if they're 6 months to 8 years and this is the first time you've actually ever gotten them immunized, they do need a second shot 4 weeks later to make sure that they have adequate immunity. I will say all my girls have gotten exposed to flu. They all have had their flu vaccine, and it's been very mild. So that's something that's really easy. There is an RSV vaccine that is in the works. It can't come soon enough. Actually, they are first offering it to pregnant women at 28 weeks of gestation to then protect babies, because we know RSV is actually the most fatal in children who are preterm, with multiple congenital, whether that's heart or lung abnormalities, and then really any child under the age of, I would say, 6 weeks, it can be fatal. So that can't come soon enough. We do have something called Synagis, which is available to anybody that's preterm. There's certain recs. So if they're less than 29 weeks of age, if they're less than 32 but requiring oxygen, or which is considered bronchopulmonary disease, or if they have any cardiac abnormalities, they do qualify this, which actually decreases the risk of them or the chances of them getting RSV. But that's not a vaccine. So that's coming out. And then COVID, of course, we keep constantly getting different variants, but that's another way to, minimize the risk of your child getting the disease, but also, or the virus, and then also the severity of it. So my children are immunized to everything they can possibly immunize against, because, although the severity sometimes of like COVID in children isn't that severe, it does have the rare chance, which we're seeing, to kind of kick up or exacerbate diabetes. And so if your kid is at risk of diabetes and they get COVID, we're seeing that they get really sick. And we're not sure why, but there's 100% a link between diabetics and COVID when it comes to pediatric patients. And they're the 2 fatalities I've seen in this pandemic. So just some quick things before we talk about the drug shortages to make sure that you're making, the best decision for your family. And then as we talk about, because this, every child is getting fevers, getting ill, we have, I'm not going to really focus on the hospital setting shortages, because now I'm a community pharmacist, which sounds so weird after 12 years of being in the hospital. But I'm going to focus on, we have Tamiflu, which is the medication that we use for the flu. So that's a huge back order. It's really hard to get. So I'm going to tell you a couple caveats for that medication. We have our liquid Tylenol and even ibuprofen back orders. Really, it's hitting harder on the Tylenol. I'll help you navigate that. And then your amoxicillin, augmentin, and cefdinir shortages, which again, I'm going to try to give you tips and tricks for that. So the first one I'm going to talk about is Tamiflu. So Tamiflu is a drug that is an antiviral that's going to work if you have flu. So I actually, quite frankly, don't like this drug. I think as pharmacists, everyone thinks that we're every drug, we're going to be like, yes, let's do it. I don't like this drug at all. So for numerous reasons in children. So one, it's really hard on the stomach. What I find is that almost all kids get really nauseous or vomit, and they're already nauseous and vomiting from the flu. Yep. And 2, which is unique in children, is that it actually causes behavioral changes. So a common thing I get from parents is like, what the hell is going on with my child? I'm like, it's normal. It's a Tamiflu. So there's certain, in my own children, who are all except one,
Mhm.
who don't have risk factors, I would say don't give it. So there's a couple times I would give it. If your child has a history of bad asthma. So my oldest, which we'll talk about, has a really nasty history of asthma that flares when she has viruses. So she's someone I would give Tamiflu to. And then the other two have no past history. So like if your child has bad history of asthma, if they're that premature child that's under the age of 2, I would give it. If they're considered immune compromised in any way, so we have like our sickle cells, our oncology patients, those are kids that I would say absolutely give it.
Okay.
It's only going to decrease their their length of the virus by about 24 hours. So in a healthy child who, has no risk factors, that 24 hours in a healthy child, and especially if they're vaccinated, isn't going to do much, and it's going to make them nauseous, vomit, have behavioral changes. Now, in an unvaccinated child, even if they don't have risk factors, you could argue to give it, but you could always just see like the first, 28, 48 hours, how they're doing.
Yeah.
But almost every unvaccinated kid that I've had that has no risk factors, they just vomited up and the parents stopped giving it. So we really wanted to be like, and for me, when I think of this is like, if my child doesn't have risk factors, if they're vaccinated and there's a shortage, I want some kid that needs it to have it. So we kind of have to think in that selfless way. That's hard if you're not a healthcare professional, because you're just thinking my kid, my kid, my kid. The other thing, like I can give an actual example is like I take care of a 107 bed long-term care facility, and these kids are sick. So when the one kid had flu, I had to call around to multiple CVS's. The normal pharmacy we get it at didn't even have it in stock. I had to call around to multiple CVS's to acquire this drug. And those are kids that you really want to have it because it will be fatal or they'll end up in the hospital. And again, I don't think we can downplay the flu. I think the most recent stat I read was there's been 150,000 hospitalizations with 9,300 deaths. So it's not something like for COVID, we all got crazy, but I think for flu too, this can be fatal. So Tamiflu, that like, again, there's a shortage, but then, depending on your child, do they actually need it? So that's the first thing before you go crazy and try to get it. I think there's a couple of things to consider. It's absolutely, in certain patients, it's great, but not all. The second thing is our Tylenol back order that we're having. So I think it's really important to just consider that there's multiple formulations before you get yourself crazy. So if your kid's over the age of 6 months, first off, you can do Motrin. I actually love Motrin unless they have any contraindications like kidney disease against it, because it lasts longer. It lasts 6 hours versus Tylenol, which lasts 4. Again, your child does have to be over the age of 6 months to get it. Some literature says 3 months, but I wouldn't do it unless they're 6 months. I'm not there yet as far as comfort, especially if you're doing it in your home. There are 2 different concentrations of Motrin, so be super careful and ask that healthcare provider before giving your child Motrin. But the Tylenol comes in various forms. I know my middle child sucks at taking meds, so we do suppositories for her, which is really mean, but she'll spit the Tylenol right back in my face. Even if it's masked.
Jenna? That's one thing as a pharmacist that I know people get all the time is my child won't take this. Like what kinds of things, because I know you're well versed, what kind of things have you already tried for, and sometimes it doesn't work. But if you have a little one you want to have take something, the one big concern is liquid formulations versus, oral tablets. And what do we do as a parent there? Or what do we do as a pharmacist to advise a parent there? But 2 is just to get them to take the liquid in the first place. So what are some things to be able to help them with just that swallowing process during the shortage? Because sometimes you've only got what you got. And if they don't like cherry flavor, that's all mom and dad can get.
So my trick is, as a Peds pharmacist, is everything. You can mask this taste of anything with the Hershey's chocolate syrup, anything. So just put that in like some chocolate syrup and give it to them. And it's beautiful. Or chocolate milk, and you put a lot of like extra chocolate and just squirt the med in there. My middle one, I've done all the tricks. she just spits it right
But
out. She can taste the
knows it's
difference.
there.
So I am the mean mom who's numerous times, the one was an ear infection, the other one was strep A. I've taken her to the ER, given her IM ceftriaxone, IM penicillin. I am a mean mom. I'm not messing around. So there's always a way to get the med in your child. Now, that being said, the Tylenol, the best way to give it for any child is to lay them back, the liquid meds, and if you can, have them open their mouth and then shoot it into the back pocket of their mouth. That way they can't, it's harder for them to spit it up. If you have them lay down and you blow in their face real aggressively, they're going to go, then you shoot it in the back of their mouth and they're going to swallow it. It looks like child abuse, but it's like the only way I could get, that's how the RNs are going to do it in the hospital.
Yep.
They're going to blow in their face. They're going to go, and you're going to shoot it right in the back pocket of their mouth so they can't spit it up.
Okay.
Now, my 3-year-old can still spit it up. So again, we do rectal. And then she will now, like the chewable, they have like Tylenol chewable tablets, Motrin. So if I actually can just give it to her and she'll take it. She likes that a lot better than the liquid, and that's more recent. But a lot of children, you can get creative because they can take like a half a tab is probably going to be close to their dose, or like, you can crush that and put that in applesauce, pudding, really any purees, yogurt. And so if that's like another way. So rectal, you always have it. If you're desperate and, you can't, and you specifically want, I don't know, Motrin as a suppository, which doesn't come commercially available, there are tons of compounding pharmacists that will actually compound it for you. It's a little bit of a to-do, but the Tylenol is commercially available in various dosage forms for children. And again, it's not that traumatizing. It's better than, it's going to get the med in there. Whereas, the Tylenol, if all the tricks I just talked to don't work, then that's what you're going to have to do. But there are tablets, and the tablets do come in lower. The chewable ones come in lower dosage forms. So you can try that. You can do a half, obviously ask your healthcare provider. And then just the regular good old tabs, you can cut them and crush them and put them in any sort of food. And so that's a creative way to get it in there. So there's always, except for the exceptions of like the really teeny babies, even them, like for anyone from like 0 to 6 months, that I like the suppositories anyway better in that age because it's just easier to give. But there's going to always be, even if the liquid's not there, with all those tricks, there's going to be a way to get the med. The other thing too that's driving me absolutely insane, and I think retail pharmacists, I am challenging you to step up. It's really, really, really killing me, and I don't think we understand the severity. So every time I've picked up a medication, so for otitis media and pneumonia, it's very easy. It goes amoxicillin, then it goes augmentin, then ceftonir. You fail that, you get ceftriaxone. A lot of pharmacists and pediatricians, like say we have like an amoxicillin, the pharmacist writes, or the pediatrician writes for amoxicillin, and they don't have the concentration that the doctor ordered. First off, the pharmacist isn't giving, I know from personal experience, not all retail pharmacists are saying, hey doc, we don't have the 250 per 5, we have the 125 per 5. Is that okay? Yeah. They're not giving the doctors all the possible choices of what they have on hand. Now, this isn't every pharmacist, but this is what I've experienced at my own personal pharmacy. And instead, what's happening is like, they'll say, oh, I know you wrote for Amox, but let's just do Augmentin because we have that available. And so what we're breeding is antibiotic resistance. And
good term right there.
In 50 years if we don't change this.
No.
So I know in New Jersey, we have no autonomy. And so if a pediatrician, for example, we went to go pick up my daughter's ceftonir because she's allergic to penicillins, which is a whole nother topic. But they didn't have the 250 for 5. So the pharmacist just said, we don't have that med. I ordered it. It will be in 2 days. I'm like, well, my daughter has a pneumonia, so I'm not waiting 2 days. So I said, well, do you have other concentrations? She said, yeah, we have the 125 per 5. I said, great, just double the dose, and can I have that? She said, in New Jersey, at CVS, we cannot just change the concentration. You're going to have to call the doctor, get a new script to get it filled. So
Wow.
that's a whole nother half a day. So I'm actually going to email that practice and just say, like, we perfecting peds or a pediatric pharmacist needs to be embedded in your clinic, because things like drug shortages, like, I'm a pharmacist, so I can navigate it. But if somebody just pulled up to the window and they said, we don't have the drug for your child, the parent's just going to say, okay. And then the kid's going to be like septic and sick in 2 days by the time they're ready to pick it up. Like,
Wow.
the pharmacist didn't say, I have another concentration. She didn't say, why don't you try Walmart or Walgreens? Like, there was no, because like these, and now it's not all, but because retail pharmacists have such a high workload, they may not be able to, not that they don't want to, but they might not have the bandwidth to go that extra mile and say,
Plan B, plan C, plan D, like, it's tough to get to because they've got another 1,000 patients waiting for them in general. But I think
yeah,
the tips you're giving, like in general, Jenna, like, how can we as pharmacists and how can we as parents be able to navigate, kind of these issues, best? All perfect. I mean, really, swallowing difficulties, like, how do we use the current formulations we have available to be able to get into our kids and make it effective? How do we use what's not on shortage, all the antivirals and the vaccines, to make sure our kids aren't getting sick in the first place? Some of the healthy and hygiene related things that we can try our best with kids, but we all know, good luck.
I mean,
That
I
one.
love, like, vitamins in kids. I do believe, like, vitamins, probiotics, all those things I
Yes.
definitely push. And even like little things on my, like, I love probiotics, obviously, when they're all getting all these multiple antibiotics. But I think too is we have to do our part as antibiotic stewardess. So we have to say, what, I don't have that concentration, I have another concentration. I don't have that drug at all, but I do have it in a pill that you could crush and put in X, Y, and Z. That's within the therapeutic window for your child. Or I have the capsules, you can open them and put them in applesauce. So I don't, like I said, I've actually emailed, I haven't heard back, the higher beings of CVS, because I mean, this is a huge issue. And little things like, if I looked at a kid's profile and I saw, oh, this kid has had, 3 ear infections in the past 6 months, they actually need tubes. If we continue down this path, they're going to have the worst antibiotic resistance. And we're using antibiotics unnecessarily when we could just be using simple, eardrops,
Yep.
antibiotic eardrops. So, like, I did it for my own children. But little things like that is where somebody that's trained and has a little bit more time,
Right.
drug acquisition. I mean, there's so many different things that, and different roles that pharmacists could have, specifically, pediatric pharmacists and just clinical pharmacists in general in the community, that we have to push for. But I think, pediatric, just pharmacists in general in the retail have a lot of things that they should do. I know it's hard with the time that they have, but it could really be life-changing for a lot of people. And like I said, like, had I waited the 2 days not knowing any better, with my daughter having, pneumonia, she did have a double ear infection, but she has tubes, like, she could be septic by then. And so these are all things that we have to consider, and we have to all kind of get creative together in this era of drug shortages.
And here's the beauty of it, Jenna. I think if anybody wants the ability to go from decision point A to B more quickly and more efficiently and know what they're doing, they've got a great resource in Jenna Quinn and the Perfecting Peds channel to be able to get that information, know more about it, and be able to make those decisions quickly on, what can be done, within their realm or scope to be more effective as a pharmacist, treating and taking care of their community, or using as a consultant pharmacist to go and, add that extra level of understanding, to their community, so they can help those peds and make sure they're living good, healthy lives and growing up the way we want them to. Jenna,
Yes.
tell us a little bit before we let everybody go with this first episode. Thank you so much for your time. Absolutely wonderful insights. But
Of course.
you have kind of a special gift for everybody inside of your channel. It's a guide related to amoxicillin. And any other details on that guide or anything else you're putting in there on this topic?
Yeah, so I'm just putting just like the FDA shortage list, which you can accrue anywhere, but then also we made an amoxicillin shortage dosing guide, just basically gives like, if you can't take this suspension, here's the tablet. If you can't take the tablet, then here's the or the chewable tablet, here's the regular tablet, here's the capsule, and then just how you would give them to a pediatric patient, because obviously they can be chewed, they can be crushed, they can be sprinkled in food. So we wrote all those things down just for parents to have a guide. And like a lot of the antibiotics, even if like insurances are shisty. So if they're not going to cover the chewable tablets, honestly, a lot of them are cheap, or the tablets in general. So you have the power as a parent to say, hey, can you just run that off my insurance and see how much that is? It's usually dirt cheap. And if it's if it's paying for those tablets versus waiting another 2 days, if you have the finances, which like I said, they really are reasonable, like $20 or less, you can do that too. A lot of pharmacists, or my personal experience, a lot of pharmacists aren't going to recommend that, but you can say for any drug, hey, run that off of my insurance, and just what would it be for cash? And that's another way. You can use GoodRx to see locally who has the cheapest one too. But like I said, not a lot of pharmacists may give you that option, but you can always say run those tablets as cash, and that way you can get it a couple days sooner.
No, I love it. I'm a big independent pharmacist guy. So if you have the ability to have a local pharmacy that is really on the bead with a lot of these things,
yeah,
great resource, and they'll be able to do a little bit more for you with it.
Yes.
Wow. But I think that for this show, thank you guys all for coming. Thank you, Jena, so much for all the insights and information. To get more from Jena and her team, head over to Perfecting Peds on RPH Ally, and then be able to check out the guide that she's put together for you, and more information to come soon. Remember to tune in with us. It's going to be every week at 7 a.m. Pacific time, 10 Eastern. And as you can hear, a great call out. That's my little guy crying that just woke up on the side. So
perfect time
to sign us out for the day. Thank you so much again, Jena. Once again, RPH Ally, head over to the Perfecting Peds channel and check out the guide that Jena's made just for you.
Take care.
Have a good one. All right. Talk to you then. Bye-bye, guys.